as I promised, so I'll be again starting to record some sessions. Whenever I'll get the chance, record the sessions. Okay, so today I want to discuss this topic, which is gingival recession. In Australia, I do very commonly see these types of patient who comes with gingival recessions. Okay, so we'll start here. So a 30-year-old woman has gingival recession. Assess her condition and discuss treatment option. So her main complaint is she's worried about this gingival recession. So what is gingival recession? It is just the shrinking away of the gums. So ideally the gum should be covering the teeth at its neck level round right here, but can you see like what's the difference between the condition that it should be in normal position and now it has gone really down? This is called gingival recession or gum recession. So she is worried and she thinks that it is getting worse. So history of complaint is she remember noticing the recession for at least the previous 5 years. She thinks it has worsened over the last 12 months. There has recently been some sensitivity to hot or cold because um, if the ideally the gum should be covering this area, but if the gum has gone down, so the root surface is exposed to the outside environment and which is more sensitive to the stimulus like hot or cold. That's why she's experiencing these stimulus, and most noticeably on toothbrushing or eating ice cream as well. It is important to document the length of time the patient has been aware of the recession and any period in which it has progressed more rapidly. It is very important for us to find out since when it has started and how it is progressing. So for the dental history, she's your has been a patient of your practice for about 10 years, and you have discussed her recession at the previous visit as well and reassured her. She has a low caries rate and generally a good oral hygiene. So despite your previous reassurances, it is also important to establish and document why the patient remained concerned. Like you have discussed this condition at the last appointment as well, but still the patient is really concerned. So you need to document it and you need to talk about it more. Why is she concerned again? Is she worried about potentially losing the lower teeth, or is the sensitivity the primary concern? You need to find out what is her main concern for today. Are her concerns related to aesthetics? The later would be unlikely in this case because this is like lower teeth, so which is not very aesthetic reason. But you need to find out what is the thing that is bothering her, either sensitivity or the fear that she's gonna lose these teeth or the aesthetic reason. So with the medical history, on every visit, you just need to find out if there is any updates in the medical history. Okay. And so she's fit and healthy and is not a smoker. So what further specific questions would you ask to identify a possible cause? First of all, you need to ask her the brushing schedule. So because you need to find out which toothbrush she's using, either she's using hard, medium, soft, and whether she's using the manual one or the electric one. So ideally the soft toothbrush is the one that we recommend, and if it is electric one it is better because with the manual one sometimes we put more force than it is required. And with the electric one it will stop if we try to force it. Some individuals brush excessively in terms of frequency, duration, and force use. Trauma from brushing is considered a factor in recession in some patients, and recession may indicate a need to reduce the frequency and duration of cleaning while maintaining its effectiveness. In these instances, the patient has a normal toothbrushing habits, but she should clean no more than twice a day for a sensible period. Like for you should be cleaning your teeth for around 2 minutes and not more than 2 times per day. Okay. Has the patient ever had orthodontic treatment? Because a lower incisor, we can see that the lower incisor is missing. It suggests that there might be some interventions done when she was younger. Fixed orthodontics in the lower labial segment is associated occasionally with gingival recession in patient with thin periodontal phenotype, because sometimes it is also related to genetics. So if someone has the thin phenotype of the gums, so their gums are more thinner as compared to other patients, so they can get more chances of getting the gum recessions. There may have been corrections of severe crowding previously. Plaque control may be compromised during the wearing of the orthodontic appliances and even over a relatively short period. In this instances, the patient had undergone extraction of the incisor but had never worn the orthodontic appliances. So first how we need to approach the patient is, first we need to do the examination. In the intraoral examination, we can see that she is missing lower left central incisor. There are unrestored teeth. There is no restorations on any teeth. No plaque is visible. We can see that there is no visible plaque, except for a small amount at the gingival margin of the lower left lateral incisor. Gingival recession affecting all lower incisors and to a lesser extent the lower canine. Okay, so it is affecting the incisors, and there is some extent that the canines are also involved. Okay, then apart from the abnormal contour, pink and otherwise the gums look healthy because they should look pink and healthy, and interdental papilla is also normal. There is a reduction in width of keratinized attached gingiva in place and absent attached gingiva. So it's just that there is a less amount of gum which is present, which should cover the tooth root. Okay, so what clinical assessments would you make and how would you make them and why are they important? So we need to work on this one. So what is our assessment? Root surface examination. We need to find out the CEJ, which is the cemento enamel junction, is detectable, and are there root surfaces concavities present? Often the CEJ is not detectable because of cervical tooth wear or caries, or it has been obscured by cervical restorations needed to establish the true degree of because with what is recession, we need to calculate how much the gums has shrunken from the CEJ. Okay, so it is a baseline that gives us what is the true degree of the recession. Should the care plan include correction of the recession by root coverage surgery prior reconstruction of the anatomical CEJ? Okay, then recession. Measure from the gingival margin to the CEJ. So how much the gums has gone down to up to the CEJ is calculated as recession. Probing depth, perform routine probing depth as well, just to find out, to find out how much is the loss of attachment undermining the reduced. So with the gum recession, it is calculated from the CEJ to the gum level, and the probing depth will be calculated how much is the loss of attachments. Okay, bleeding on probing as well, just to indicate how is the health of the gums. Gingival thickness, you can just observe with whether the probe is visible on insertion in the gingival sulcus of the receded area or not. If the probe visibility indicates a thinner periodontal phenotype and more likelihood of developing recession, then there would be the likelihood of completely covering the roots with advanced graft surgery is reduced. Okay, then amount of attached, you need to find out how much is the attached gingiva present. How you can calculate it is by subtracting the probing depth recording from the width of keratinized gingiva. You just need to subtract the probing depth from the keratinized gingiva section. Okay, so a presence of functional attached gingiva, you just need to find out how much is the attached gingiva present. How you can find out that is, you just pull the lips gently or depress the labial sulcus mucosa, placing tension on the gingival attached gingiva or gingival margin. If the gingival margin is displaced from the teeth or is otherwise mobile, then there is an inadequate width. But if it is completely, so attached gingiva is just like it is attached to the teeth, right? It is hard and it is attached to the teeth. So if by pulling the lip apart, you can see that there is some displacement of the gingival margin from the teeth, it means that there is very less amount of attached gingiva present. You also need to find out if the tooth is mobile or not. Just try to displace the teeth buccolingually using two instrument handles. Fingers are too compressive to this to do this effectively. Important if teeth are very wobbly and but not a very useful diagnostic or prognostic indicators. Sensitivity test, you just do the routine method of electronic pulp tester or hot or cold test. Occlusion, just perform direct examination of intercuspal position and exclusive contact. Just let let the patient bite on their teeth and just to ask them, just grind your teeth or open side, open close, because we just sometimes the trauma from occlusion can also increase the severity of the gum recession. Okay, so on performing these examination, you find out that the probing depths are 1 to 2 millimeter with no bleeding, which works with the like healthy gingiva, as we can see. And the width of the keratinized gingiva varies with the degree of recession. The lower left lateral incisor has no attached gingiva, and tension on the lip displaces the gingival margin. No teeth have increased mobility, and no possible occlusal factors are present. There is no reason to suspect loss of vitality, and all the teeth respond to the testing. Investigations which radiographs are indicated. Radiographs would just give little additional information. These degree of bone loss on the buccal spectrum, including bone dehiscence and fenestration, is not shown well on the radiographs because of superimposition of the roots. So radiograph might help if interdental bone loss is suspected, but if there is intact interdental papilla, then together with minimal probing depth, it suggests normal interdental bone height, and radiograph would be of value if mobility indicates a need to assess the root length and bone height. Okay, in this case, x-rays are not really helpful because we can see whatever is happening with the gums. What is your diagnosis? The patient has gingival recession. In this case, the assessment has not been provided. Diagnosis any more accurate than that given by the patient, but the features should give some clues to the possible etiology. Recession is probably multifactorial in etiology because we do not know what's the actual reason for the gum recession. The most important factor is probably anatomical variation, sometimes how the teeth sits, if there is any crowding, or if they are like normally they are placed in more buccally, they are more likely to have recessions. Okay, when the buccal plate of the alveolus is thin, there is bony dehiscence and or fenestrations below the soft tissues are more likely. For these reasons, there is more recession on the teeth that are prominent in the arch, and least on slightly that are with teeth that are in standing, they have little bit less recession as compared to the teeth that are placed more buccally. There could be some predisposing factors. So the most important could be traumatic toothbrushing, or the plaque-induced marginal inflammation, or the traumatic occlusion. All these factors can contribute. Okay, then what advice and treatment would you provide? Ensure a sensible, atraumatic but effective brushing. So how we can ensure that is resume to remove even the small amount of plaque, and explain the importance of good oral hygiene in case of recession. Often patients will need precise demonstration of how to clean. You just need to give them the demonstration how to clean the teeth. Some people think that you just need to scrub the teeth hard, which is not the right procedure. You just need to explain them if you are using manual toothbrush or the electric toothbrush, how to what points you need to consider. With the manual toothbrushing, no worse than power toothbrushing if done correctly. Areas of current inadequate plaque removal should be addressed by demonstration. You just need to explain them the different brushing technique, which is the Bas technique, directly in the patient's own mouth, such such that patient can subsequently demonstrate correct placement. And so you just need to demonstrate in their mouth so that they can learn where to place it correctly and what technique they need to use. Toothbrush heads should be compact and large ones restrict address access. Bristles should be flat or either and either soft or medium stiffener. But we do not recommend even the medium one. We just recommend the soft one. Okay, then the powered one clinical trials show more effective. They are better than the manual toothbrushes. And however, difference in effectiveness between different modern types, which there are different types like rotating, oscillating, sonic, vibratory, are negligible, often used incorrectly. So advise them that you just need to put on a single tooth for 3 seconds and just move on the different one. It will do the work. Additional functions such as you can also use the timers or pressure sensors, so you will which are more helpful in compliance. And the interdental cleaning, it should be done daily. Ideally, the interdental brushes checked for correct size intraorally. For different teeth, there could be different sizes of the interdental brushes that you need to use. Floss should be used between teeth where the brushes do not fit. Mouthwashes should only be used as an adjunct and should not be used daily. Medication method, evidence of limitedness, and it is not very recommended. So these are and also reassure your patient that the condition is not necessarily progressive if optimal oral hygiene is established, and just continue to monitor it by taking clinical photographs and doing study casts. Okay, but if the patient complained that he or she is experiencing the sensitivity, then you should do the treatment for the sensitivity. There are different treatment that you can do. Recession alone should not be painful. Ensure that the exposed root surface is suffering neither early caries nor erosion. So check the diet for like if they are having sugar, acidic drinks and food, and check the medical history if there is any like gastric reasons. Advise use of high strength toothpaste. Long term use of these agents show good effectiveness. And also, however, studies are inconclusive, but you can just there are different treatment options that we can give them, like for example calcium carbonate. So it comes in the toothpaste and the prophylaxis paste form. They are more effective than conventional fluoride, and they do have potassium toothpaste as immediate and long-term treatment. No good evidence of severe. So these are different treatment options that you do. Mainly which are more common is the varnishes and also the high strength fluoride toothpaste that we do. But we do have these options for the sensitivity that we can do for the patients. Okay, so and other, if they are asking for the treatment option, like for the gingival recession, then the treatment would include either the mucogingival surgery to correct the recession using either coronally advanced flaps. So these surgeries are mainly done by the specialists. As a general practitioner, we are not qualified enough to do these surgeries, so we just need to refer them to the specialist if they are really concerned about the gum recession. Okay, so because these surgery, it will cover the area and it will provide the better attached gingiva there. All right, so this is the chapter, I think. Yeah, so hygiene is the reason that we this. Okay, so what do you see is the graft successful? So this, for this patient, she has undergone the graft surgery because she was really concerned about it. But it's just more like a specialist thing. I won't recommend, going into specialist thing. Just um, find out what, as a general practitioner, you can do in these cases. Okay, so most likely we need to focus on these things because generally patient comes with the sensitivity, so we can just focus on what we can do for the sensitivity and find out the reason for the gum recession, and also check with them about their brushing habits and brushing like techniques what they are using. Okay, I hope that this session will be helpful for you, and thank you so much for watching.